we have to introduce our. I'm not see if he's online. If Joe, you are with us, okay? And Joe is an expert in football, so that's why he's here. And as a hobby, he is involved in PICU, especially in treatment of septic shock and in ethical problem. And but today he will give us a lecture about use of inotropes in the septic shock, right? Or you want to speak about Everton?
See. Okay.
Okay, thank you, Joe.
It's going.
Yes, we can see your slide now.
Buonasera a tutti. That's my Italian finished for the evening, I'm afraid. So I'm going to talk about endpoints of resuscitation, inotrope choices in pediatric sepsis. Usually I try and make sure I don't contradict any of the speakers that have gone before, but luckily I don't understand anything of the last several hours, but it all sounded very good. Back on again. So I'm an intensivist, and I do bioethics as well in a hospital that's still part of Europe. Predictable things in sepsis. Oh dear, I better not show that. So there are the new surviving sepsis guidelines that have come out, the Surviving Sepsis campaign. And I would ask you all to go and look at them. They're very evidence-based. A large group of us worked on them. And the initial resuscitation algorithm for children is there. The first 1 hour of resuscitation from septic shock, 3 hours for sorting out a child with severe sepsis suspected. And really the key messages there are for you. I'm going to go through most of those in my talk. Some of this precedes this, some of it's my thoughts as well about how we should do things. So very early directed treatment. And then more specifically, there's an algorithm for considering fluid and vasoactive inotrope management. I know you've had a really good talk on fluids already, so I'll focus on the inotrope parts of that. So our resuscitation courses that we all do, European Pediatric Life Support courses there, actually teach resuscitation really well. They teach us to work out whether a child has compensated or decompensated shock, to intervene early with compensated shock, thinking about heart rate, pulse volume. And the key message here is that blood pressure dropping is a very late sign in children. So we look at perfusion, temperature, and end organ effects. So the sleepy child, the child not having many wet nappies, they're all more worrying than kind of a low blood pressure, which is an incredibly late sign, and we really should have intervened earlier. So I would ask you, why in ICU, when we have all these things, do we suddenly talk about wanting one magic variable to target to resuscitate in septic shock? So SCVO2 was a very influential thing about 15 years ago to measure. I'll come on to what that is and the theory behind it. But I will take you back to medical school, physiology. So whenever you're treating a child with sepsis, I would ask you to go back and think about physiology by the bedside. Cardiac function is made of systolic and diastolic function. Diastolic function, very hard to measure at the bedside without a very competent echocardiographer. Rate and degree of ventricular relaxation with active passive components. So we spend most of our time thinking about systolic function. And we often talk about blood pressure because we can measure it really easily. But blood pressure, of course, is composed of cardiac outputs and systemic vascular resistance. Cardiac output, heart rate times stroke volume. And stroke volume, we often talk about in the ICU, optimizing stroke volume, trying to sort out preload, contractility, and afterload. And that's really what our fluids and inotropes are really targeting when we think about managing severe sepsis. Systolic cardiac function, 4 interdependent factors: heart rate, preload, contractility, afterload. We measure heart rate. You can measure it with your pulse on yourself right now. Preload, we can do invasive pressures. CVPs are used more in pediatric ICU. In the old days, when Luca and I were young, we put Swan-Ganz catheters in and measured pulmonary artery wedge pressures. That was great fun, but probably didn't help anybody. And then contractility is quite hard. You might think you can do fractional shortening or more complex echocardiographic measurements, but they're not particularly useful. and quite hard to interpret. Conductance catheters have never really come into the ICU. That's a very complex, invasive way of measuring contractility very, very accurately. And often we really do bedside cardiac output using echo, Doppler, that sort of thing, or other devices that have increasing degrees of cost. I would ask you probably to think, before we go on to the targeted parts, to think about the adequacy of cardiovascular function. Is it working well enough? What's the adequacy of cardiac output and oxygen delivery? Thinking about how we are targeting things here, what about a global assessment? The initial stuff that was done in the old days is really about mixed venous oxygen saturation. I'll come and explain that. We measure central venous oxygen saturation, which is the saturation taken from the junction of the superior caval vein and the right atrium. And that's something that obviously needs to have a neckline in. And I love nothing more than putting necklines in very coagulopathic septic babies. Lactate's a bit easier to do by the bedside. Most of our blood gas analyzers now have a readily measurable lactate, and I'll talk a bit more about that. We also have regional assessment, capillary refill, core peripheral temperature graph, and more experimental things are involved as well. But I think I push you more and more in pediatrics to think about secondary organ effects, renal, hepatic, and particularly neurological systems in early management and assessment of sepsis in small children. The caveat is also that cellular viability is not just about oxygen delivery to the tissues, which is vital, and our focus is intensivist, but also microcirculatory function and oxygen extraction, the function of the mitochondria. Very important, not a lot we can do about them, and I'll justify that a bit later on. Two key components of delivery of oxygen are oxygen uptake in the lung, and that's a whole different lecture, talk about how you get oxygen uptake in the lung with ventilation, with PEEP, with other stuff in sepsis. But the transport and delivery of oxygen from the lung to the tissues, cardiac output, stroke volume. What about these magic variables? The contenders we have, I've mentioned already, those two global measures of cardiovascular performance are really acting as a proxy for cardiac output and that entire system of delivery of oxygen to tissues. But we can also think about hemodynamic variables themselves. We can measure them. Cardiac index by the bedside, SVRI, looking at the vascular resistance, and microcirculation is certainly measurable at the bedside, as is near-infrared spectroscopy. These are all things that have been considered and thought to be our major variable we want to push as intensivists and optimize. I'll come back to this picture, which is quite old now. Little girl's gone home and done very well, but it's just a little appeal for you to think not just about blood pressure. By the bedside, we can look at blood pressure. It's very easy to measure, but blood flow is equally important, if not more important. So the point I always make is the child on the left has a higher blood pressure than the child on the right, who's obviously on open chest ECMO, is vasodilated, warm, well perfused, and child on the right is vasoconstricted with a very reasonable blood pressure, but very poor blood flow. The other thing that we can't forget, and I'm sure this is the same in Italy, most of the deaths from sepsis, and this is old data when we had a much higher mortality from sepsis in the UK than we currently do, but the deaths are almost all early. Many of them are before the child even gets to the intensive care unit. So the marginal difference we can make by optimizing things in the ICU 6, 7, 8 a day later is not much compared to what we could do early on trying to get an optimized treatment there. It's a general principle that if the child is dead, it's no point coming into the ICU. So we need to think about doing things early and getting treatment to children early if we're going to intervene in those children that are dying from sepsis currently. The story started, I think, probably 2004-05, when the Rivers Group in the US had a big publication looking at central venous oxygen saturations and trying to drive treatment protocols based on increasing CVO2, central venous oxygen saturation. And if that's low, the idea that you either have cryptic shock, if you have other features of shock, you have overt shock, but by improving the SCVO2 with fluids, inotropes, blood, other things, that's the target you had. And they showed a very big mortality reduction. Single center study, and a great lesson, because many people took this as absolutely what we should do and rushed off and developed protocols. People invented central venous oxygen saturation catheters, made us put them in children. We all tried to get them to work, and it was very hard. And actually, this is the sort of thing that was done. Early goal-directed therapy, trying to get stuff done quickly in the ED because of the Rivers paper. But no other group, when people did this in larger scale, multi-center studies, had anything like the effects. And to cut a long story short, that's largely because the control group mortality was much better in other centers. So the interventions that people were suggesting raise a high mortality, well, drop a high mortality to low mortality. But in many centers where the mortality was already relatively lower, you don't see the improvement. So that really went out of vogue. It's still mentioned occasionally. We will still measure it, something you can look at. We don't use the catheters anymore. We do a neck vein saturation, which gives us an idea of how sick the child is. Measuring SCVO2, why do you do that? Well, the idea for those who haven't done much ICU, if tissue blood flow is inadequate to meet oxygen demand, your tissues extract more oxygen. And that leads to a fall in the oxygen of saturated blood coming back to the heart. So if you have a sluggish circulation, a poorly functioning cardiovascular system, you have desaturated blood coming back to your right atrium in the normal healthy state. Obviously, if you have congenital heart disease or some other problem, that doesn't really work so well. But as a result, the idea is venous oxygen saturation is measured, and if it's low, it's often a problem of global cardiovascular performance, and resuscitation leads to it going up. The normal is about 65% or more, and often in severe sepsis, it might be 45, 48, and certainly as children get better, you can see this number come up. What about lactate? Well, I think, Luca, I think you're a cyclist, I can't remember, but you know, the idea that lactate goes up when you're cycling because you're exercising, and we're all aware of that, and people talk about lactate burns and anaerobic metabolism versus aerobic metabolism, and actually very interesting, but nothing to do with sepsis. In fact, it's increased aerobic glycolysis in skeletal muscle secondary to epinephrine stimulated activity, not anaerobic glycolysis from hypoperfusion that leads to a lactate going up in sepsis. And this is really important because I'm sure you've all looked after sick children with asthma. When you get them an IV salbutamol, you notice the lactate goes up. They are not running a race. They have not got cold peripheries. They are not hypoperfused, but they have a lactate rise because of the effect I'm talking about. One issue with this is adrenaline, of course, is poor man's salbutamol, not selective, but a similar effect. And obviously this means that with adrenaline, your lactate can increase. And it is a problem in terms of severe sepsis when you've got a high lactate and you're measuring lactate coming down. I'll come onto that as a target, but on adrenaline, it might not come down as much as it would otherwise do. So rather than a single lactate, it's been found that changing lactate levels are something that's reasonable. As I mentioned, SVO2 being a target. Similarly, lactate being raised above 4 at the moment is the current cutoff that leads to resuscitation targets and attempts to reduce that. But often in severe sepsis, it might be 7, 8, 9. And current theories are to reduce that by the things we do to resuscitate from sepsis. You've heard about already: fluid balance optimization with boluses, inotropes, other things to increase hemodynamic performance, which might involve temperature control and muscle relaxants, that sort of thing. So targeting lactate is kind of the vogue at the moment. There was a few papers in the early 2010s wondering whether SCVO2 was superior to lactate. In fact, the data from larger studies shows that lactate clearance is superior than SCVO2. And as I say, in children, I'm really happy to put a peripheral line in and get a lactate out of it. Even a big free-flowing line's beautiful. Femoral catheter is good, but I don't like putting neck lines in very sick small babies. I'm just a wimp with the coagulation problems. Think about other targets. What about hemodynamic variables themselves? So rather than measure a proxy for cardiac output, measure it itself. Well, Mark and I did this work in, 15 years ago now, showing that pediatric septic shock is very different from adult septic shock. Those of you who looked after adults, perhaps recently during the COVID pandemic, will know that adults come in, they have a low SVRI, they have vasodilated septic shock, they're on noradrenaline, and then some of them die, the way it is. In fact, in pediatrics, there's much more of a mixed picture. Many children have a low cardiac index, and they might have, as we showed here, a high SVR or a low SVR. So very interesting that children have a different picture, a morphology of their septic shock from adults. I'll show some data later that in children, unlike adults, the morphology, the character of the septic shock they have changes in the same child. They may have a high cardiac index at presentation and that will drop, but more often those with a low cardiac index will eventually flip and have a higher cardiac index day 2 or day 3. And if you don't measure that, you will end up on the wrong inotropes, driving a cardiac index when it's already 7 or 8. So there you go, put that there. So some initially have a high cardiac index, then phase delayed. And my argument would be, if you don't measure this or quantify it, you're going to miss that change in the fundamental hemodynamic status of children. Okay. And actually, if you go back to the kind of the original algorithm before the Surviving Sepsis campaign recently, the ACCM guidance, it really still talks about heart rate thresholds for the second phase, optimizing cardiac index in the ICU, trying to normalize CVO2, but also lactate clearance. That's the old version there. What about other targets? Well, microcirculation. I don't want to say anything too negative here, really. So if most of the deaths in childhood are occurring early in sepsis, I don't know which of your units has a microcirculation machine you can get down to the ED department and get measuring microcirculation in sick children who come in. We certainly don't have that. They're expensive. More importantly, the data is very hard to work out with them. In the new version of the SSC, they don't feature. And you have wonderful images from these amazing researchers who can show you that blood flow in the microcirculatory area is much worse in people dying of organ failure and septic shock. Okay, but you can't change it. You can't intervene or do anything with the microcirculation. Maybe one day that will change, but at the moment, I think it's a clever tool for people. It might be something you'll get research grants for looking at, but I can't see it improving the outcome of sepsis, and we will not measure it in children at the moment. You can certainly predict some changes, but what about near infrared? Well, it's the same story for me, actually. We played with this for a time, and again, it's quite expensive. Trying to get it in children and have it reliably on when you have any child with sepsis coming in from an early situation is really hard. And we didn't find it particularly helpful. Again, if a child is doing badly, they will have low STO2, tissue oxygen saturations. But you know that anyway. The saturation probe won't work as well. They're poorly perfused. And I don't think anyone's shown that targeting this in sepsis makes any outcome difference in children at all. So what do I do to finish this bit of the talk? Well, a reverse shock. The SSC probably, wouldn't quite go with me on this, but this is what I do versus what our international evidence-based recommendations. Normalizing cardiac index SVRI and DO2 seems sensible. That's why we're on inotropes. We're on inotropes to optimize your circulation, but the macro circulation. And with most children, that will lead to improvement, as Akash and I showed in that paper some time ago. If you're really struggling with persisting shock, yes, you have ECMO, there's some data for that. Plasma exchange, there's a couple of papers about that, but again, not strongly recommended. And renal replacement therapy, for instance, there's no supportive data. And I heard a really nice talk on nutrition and other stuff, but most of the other stuff we talk about, there is almost no evidence for their use in children with severe sepsis. There's a lot of research to be done, guys. What to target? Well, this is the mistake I think people have made for many years. Not one target, not one parameter. It's the global assessment. Optimize DO2, sure. Normalize that physiology, get lactate down. Core peripheral temperature is well under respected in pediatrics. Cold shock with cold peripheries, resuscitate till it disappears. Hemodynamics, we do measure. We try and optimize them. End organ effects, urine output, the old fashioned stuff. Looking at tissue viability, all that kind of stuff. Inotropes. What do I do with inotropes? Well, pediatric and adult shock are different, as I've already shown you. So why would we use the same inotropes as the adults use? It makes no sense. Perhaps principled physiological treatment of derangements is similar. And again, do we have data rather than just consensus on inotropes? Well, the adults are quite clear that norepinephrine, noradrenaline, is superior to dopamine in their low SVR patients with high cardiac index, the standard adult pattern of septic shock. Dopamine proven to be worse, noradrenaline superior. Okay, but that's not the sort of shock we have. What about children? Well, there is some data about the first inotrope you should use. And Ventura's data is still the best we have from 2015. And they randomized children to dopamine or epinephrine, either intravenously, peripheral line, or interosseously, In 120 children with severe sepsis, quite an undertaking. Dopamine doses there, epinephrine doses are there. Baseline characteristic therapeutic intervention similar, and the deaths are quite striking. And like most pediatric studies, it's small numbers, it's a single patient study, but you have increased death, healthcare associated infections. Both of these were shown in adult papers with dopamine compared to noradrenaline. And with epinephrine, you have an odds ratio of survival of 6.5. Pretty good stuff. More recently, Ranjit's done some work with Marek helping out from America and India, showing that noradrenaline peripherally is an equally good inotrope to start. So they did a work looking at the safety of noradrenaline, norepinephrine, and I think our current SSC recommendations I'll come on to, but really depending on the shock morphology, either of those are reasonable. Giving them via peripheral line is reasonably safe in the low dose ranges we use initially. And that's the initial surviving, or the ACCM guidance stuff about getting the second IV line in, getting inotropes started early. So really, to come back to the Surviving Sepsis campaign, after this, there is little randomized control evidence of anything in pediatrics. So I'll tell you again what I do. I think this is useful in places, healthcare systems with intensive care. So Italy, the UK, Europe, and you may argue why the Surviving Sepsis campaign has most of the stuff here given to places that don't have intensive care. That's largely because of the FEAST study, Kath Maitland's work, which really influenced things about the harmful effects of fluid if you can't deal with the consequences. And I will argue that remains the case in our intensive cares too. And I'm sure you heard about that with the fluid talk. But you see, if signs of fluid overload are absent, give 10 to 20 mils per kilo, obviously preferring isotonic crystalloids over other stuff. Repeat boluses can be assessed once you've assessed the hemodynamic response. One of my big arguments is giving a bolus of fluid is basically being by the bedside, looking at it going in and assessing the response to fluid and building your own lovely curve to see whether the cardiac index, if you're measuring it, goes up if you give fluid, or actually goes down if fluids are harmful. So you're trying to look at every stage now with all the current guidance, including the World Health Organization, ETAC guidance, all the SCCM type stuff now, and the Surviving Sepsis. You're looking for fluid toxicity very early, very, very early. So you're trying to work out whether the fluids are actually being harmful, but knowing at the same time they may be helpful. And essentially what you're doing is you can plot your own Starling curve of fluid responsiveness. It goes up, you give more, it goes up, it doesn't go up, or sorry, if you give more fluid, if the cardiac index or your hemodynamic assessment doesn't get better, don't give any more fluid. And here we currently say, consider epinephrine if there's myocardial dysfunction. How do you assess that? Well, it's in the guidance, but it's quite hard, I think. Epinephrine, norepinephrine if shock persists after 4 to 6 mils per kilo. So we're very woolly on inotropes. There you go. I think Akash and I showed this in that paper back in intensive care medicine. Most hemodynamic effects will improve, and the evolution of cardiac index during an ICU stay is to normality in survivors. Questions? Yes, I have lots. I did have something else. Yeah. The point here is once you've given that first inotrope, either adrenaline, or if you look at the SSC campaign now and you're worried about stuff, maybe noradrenaline, but you need to look at the effects. And obviously, if you have a child who has a low cardiac index, a high SVR, you've started adrenaline, and it's not quite clear things, then the mixed drug you might use might be an inodilator like milrinone. If you have a child with persisting low SVRI and a high cardiac index with the adult pattern of sepsis, you'd be with noradrenaline and you might be adding vasopressin. So actually the inotropes used depends on the evolving morphology of the septic shock state. And I would argue you need to measure that Doppler, whatever your current device is, but actually guessing by the end of the bed with a finger on the toe is not really good enough for inotropes, and nor is measuring blood pressure on its own. Think about that global assessment of everything. So I'm back to my bit about questions now. So yes, I have a lot. There's a lot of stuff to be worked out in sepsis and a lot of grants to be got trying to get this sorted out. Grazie mille for the invitation. As you can see, I don't just like football. That's the England rugby team beating Italy at the top left. But of course, that's our current manager, the wonderful Carlo Ancelotti. Thank you, everybody.
Thank you very much, Joe.